for joining us for this briefing. I'm going to start by talking about the format of our briefing for today, and then I will go ahead and introduce our panelists. Just as a refresher and as a reminder, this is the briefing on the tuberculosis case at American. And I have with me several colleagues from American University, as well as our colleagues from the DC Department of Health with us this afternoon. Our community received a memorandum that came from Dr. David Reitman and myself yesterday afternoon, notifying you of a case of tuberculosis that we had been notified about. And we included it with this communication, a link to the CDC website for additional information so that folks could immerse themselves a little bit on what tuberculosis is. And also we outlined what the process would be in relations to contact investigation. And so we thought that it would be helpful this afternoon for us to just be able to spend some time with you. Thank you to our community for clearly taking the time to read that information and for your interest in the topic. This afternoon, I have with us Dr. David Reitman, who is the head, the medical director of our center for our student health center here. I also have with me our colleague Leanne Wright, and Leanne actually has been leading our contact tracing work internally for COVID. She's the Associate Director for Environmental Health and Safety Risk Management here at American University. And then I'd like to introduce our colleague from the DC Department of Health, Jason Beverly, to say a little bit more about his work at the DC Department of Health, and along with Dr. Emmanuel Rosario as well from the DC Department of Health. We are in coordination with them and we're working hand in hand around the case. And so with that, maybe Jason and Dr. Rosario, if you can perhaps introduce yourselves a little bit to tell our audience a little bit about your work.
Sure, thank you, Fanta. And thanks to American University for your partnership thus far in handling this case. I'm Jason Beverly. I'm a family nurse practitioner, and I'm the interim division chief for STD and TB control here at DC Health. When we say DC Health, that's the same as DC Department of Health. I'm here with Dr. Rosario, who is an infectious disease specialist and a TB specialist here, seeing patients in our clinic, our TB clinic here at the Department of Health. And so we're the ones working with the contact investigation for this case. And we'll talk more about what's involved in the contact investigation and how we're going to proceed with that. But we're taking the lead in determining who is close contacts to this case and who requires testing and how best to accomplish that testing for your community.
Thank you to both of you for being with us this afternoon. We very much appreciate it. I think to get us started, it might be helpful for us to start with medical information, confidentiality, and the importance of that. And so perhaps Dr. Rosario, Jason, and Dr. Reitman, perhaps you can set the stage for that, because I think it's quite important. We're getting questions like what hall, what individual. We're even getting questions, and we've gotten call from people saying, you know, my student was at some event with this individual, and we're able to say not possible because the individual was not here at that time. So we're hearing a lot of rumors that I'm kind of concerned about, and I just want to start with, first of all, how important it is, the confidentiality of medical information for individuals, and then we can kind of jump in.
I can just start off real quick, and then I'll pass it off to the Department of Health. You know, as a covered entity under FERPA and HIPAA at the Student Health Center, we are required to keep patient confidentiality as a utmost priority. Our students expect that of us, and legally they are entitled to this. Whenever there is a public health emergency or public health situation, we do have to balance sometimes what our confidentiality practices with making sure that we are going to be able to perform to do a public health investigation. That said, we cannot compromise the privacy of any of our students here at American University. And one thing that I can just, assure anyone of just, who's here is that if their student was diagnosed with a communicable infection, we would not want to compromise any of your students, medical privacy, and the same holds here. So we will not be able to confirm or deny anything about where the student's name, the student's whereabouts. We will not be able to talk about specifics about who the student was around, what the exposures were, where the student was going to a party, classes, anything like that. All this information is known and is being used by the healthcare professionals involved here, both us as well as the Department of Health, to do a comprehensive investigation, to do contact tracing. But we have to do this with the intent of maintaining our students' privacy. So I would just request, that people not ask questions about who is the student, how can I know if the student, if my student was exposed to him or her. This is something that I promise you we are going to be doing a very, very in-depth investigation with, to make sure that we get do our contact tracing, but we cannot answer individual questions or specifics about how the student may have contracted TB, underlying medical issues, anything else that would compromise the student's privacy. And that's where I come from as the doctor here. I'm going to turn this over to my public health colleagues for them to talk about how they do things from a public health standpoint and complement that.
Yeah, just to add to what we were saying, in a way, medical information is confidential, and then that's the HIPAA law in a way. Mm-hmm. And but given that, the health department, is responsible for the contact, investigation. It's a thorough investigation of contact investigation, and whoever needs to know who is at risk will be informed, and all the appropriate tests will be done. So mm-hmm. there will be nothing left. Everything will be done, but the identity of the index case is always confidential, and then that's how we have been working, and that's the standard everywhere you go. So confidentiality is the utmost importance.
Yeah, and it does get difficult because we're talking about doing detailed tracing of contacts, and so we are asking people to share information with us, but we're not allowed or able to share information back, and that can be frustrating for people who are genuinely concerned about their welfare and their friends' welfare and their family's welfare. But we really have to be careful about what information, if any, we are allowed to share, and specifics about patient, about the case, the index case, or the contacts, we cannot share. And as frustrating as that is, we're very strict about that.
Thank you for setting the table on that, because I think it's important. So I think there's a couple of questions that I just want to start off with, because based on the questions that have been asked, I think we need a TB 101. And so can we just start by the conversation a bit? I think we need to refresh people's mind. What is tuberculosis? Because one of the questions that came up already was, isn't everyone vaccinated for tuberculosis? So already the fact that we're talking about vaccines tells me that there's not an understanding about what tuberculosis is and how we actually deal with that. So perhaps we can start there and talking about what is tuberculosis, how does it get transmitted, what are sort of the symptoms and so forth. I think that might be a starting point, if you all don't mind.
Sure. So, I mean, TB is a disease that typically affects the lungs, but it can affect all parts of the body. It's a bacterial illness that can cause symptoms in its active disease state, can cause symptoms like cough, fever, blood in the sputum or a bloody cough, weight loss, night sweats, profound fatigue. These are things that can present in active disease state. But TB can also cause what we call latent infection, which means that the person doesn't show any signs or symptoms, is not sick at all, and cannot transmit, it's not contagious, cannot transmit the infection to anybody else. And the majority of people that have TB across the country and across the world have what we call latent TB infection. So active TB disease, by comparison, is relatively rare. However, as we can see here, we do get cases of active TB disease like we're dealing with. TB is spread when someone who has it in their lungs coughs, sneezes, sings, laughs in a closed-in area, poorly ventilated. These are things that can cause the TB to be spread to other people. Again, that's in a person who has active TB disease in the lungs. TB is treatable, whether it's latent or whether it's in its active disease state. We have effective treatment for TB, and we have access to it here. We provide it directly out of the clinic at no charge to individuals. And so that, as scary as TB is, because it's airborne transmission, the immediate message behind that is we have effective treatment. And if you have latent disease that's not making you sick and you can't transmit to somebody else, we have effective treatment for that. Or if you have active disease for TB, we have treatment for that.
And can you clarify the treatment, because people are talking about vaccine and it's really not a vaccine.
Oh, yeah.
Treatment. So can we please clarify that for everyone's sake here?
I think this is the common question that we get here in the clinic, and people come, hey, I've been vaccinated as a baby, and why do I have TB? The vaccination, which is called BCG vaccine, is a vaccine given in places where TB is very common. And usually it's given for babies or for children. The purpose of that vaccine is for those babies or children to get some partial immunity to TB. So if they get TB disease, it will not get very severe, because children, since their immune system is not that much developed, if they get active TB disease, there is a risk that it can progress much more faster. If they are vaccinated, then that progression will not be as fast. So the impact of that active TB disease in babies or children will not be as much if they have been vaccinated. But that vaccine just only works for babies or for children in the endemic area to decrease the severity of the disease. But in adults, that BCG vaccine went with time and is not protected. So we don't have any effective vaccine at this time for TB. So that is the common question that we get, and we try to explain to people, we don't have any effective vaccine at present time. And BCG is not given in places where TB is not that common.
For example, in the United States would be the example, right?
Right.
That it's not giving out, it's not giving the US, given that there's very low prevalence of TB to begin with. And so if vaccine is not the regimen, how do you actually treat TB then?
That is a very good question too. TB has two stages, as Jason was saying. One is what is called the latent TB infection. This is where a person has been exposed, the bacteria is in the body, but it hasn't progressed to a stage of a disease. And this is very common. About 1 out of 3 people in this world have been exposed to the TB bacteria because it's an airborne disease. But out of this, people, that 1 out of 3, about 5 to 10% will develop TB, progress into active TB disease later on in life, especially when people's immune system is compromised, or if they have some diseases that affect their immune system, then that latent TB can progress into active form of TB disease. So that can happen. And the treatment for active TB disease is medications. There are pills that are taken. Usually we use about 4 types of pills. One is called INH, the other one is called rifampin, the other one is called ethambutol and pyrazinamide. In combination, these medications are given to the patients, and based on what we call sensitivity result of the bacteria. The bacteria, we always follow if the bacteria is sensitive to those medications that we have prescribed. So these are the medications, and usually the treatment of TB in the lung or in the lymph node can range from 6 to 9 months. And the good thing about TB is curable and treatable disease. So that is for active TB disease. And for latent TB, for people who've been exposed, but they haven't developed active TB disease, they can also take medication to get rid of that bacteria from the body, so it doesn't progress into active TB disease later on in life. So we have regimens ranging from 9 months to the new regimens that we're giving for about 3 months treatment. there's a medication that they can take once a week for 12 weeks. And we provide all the 3 regimens here in the health department TB clinic.
Yes, very helpful. David, you wanted to chime in. Please go ahead.
Yes, thank you. I've gotten a number of questions from students today and from parents about the TB vaccine, which I think is a little different than maybe what the Department of Health is maybe hearing. Just like they said, in the United States, people do not get the any TB vaccination. What people do see when you look at your vaccine records are there is a TD vaccine, that's tetanus. Okay, so you've gotten that. That's not tuberculosis. Okay. The other thing is that some people, when they look at their vaccination records, there's a date next to tuberculosis. That doesn't mean you got a vaccine for it. That was the date that you were tested for it. Okay, at some point. I also just want to mention that for any student that was coming in from abroad, okay, or actually for every student, we asked when they started this year, we asked them to fill out a TB questionnaire, asking questions about, have you ever been in a country that was high risk or endemic for TB? And students who answered positively to this actually did receive a required tuberculosis test when they got here to American University, and to determine whether or not they had latent tuberculosis, like our Department of Health colleagues were mentioning. So there are a number of things we've had in place also that to make sure that if somebody was coming from a place where there might have been a risk of endemic tuberculosis, that we caught that and were able to test for it as the people entered into the university community. And this has been done with students. This is actually part of a policy that we've had at AU for about 2 years that we do with students when they're incoming from high risk areas, or they had any kind of other exposures that might be high risk for tuberculosis. I just wanted to clarify that about also the vaccines. Go ahead.
Thank you.
Just to add one thing to that, I mean, I learned a lesson today that the tetanus. People also think that the tetanus vaccine is a TB vaccine. Yes. I think that's a good education. But one thing that I want to add here is that when people are coming from endemic area, we recommend that instead of giving them a TST that can be affected by the BCG vaccine, to do the IGRO test, because that is not affected by the BCG vaccine. So that will be a great help, because we were having a problem before in some of our investigation that people who came from endemic area had the TST. Then it's very difficult to interpret whether that TST is due to the BCG versus due to the infection. So I think one important thing to pass would be for patients who are coming from endemic area, had a BCG before, when they're screened, it's good to do the IGRO test rather than the TST.
Helpful. So I want to jump into what I know the audience is here for substantively. And I want to really get to the substance part of this. So we're going to hear from some people. I was next door to this person. First of all, the question is, how do you actually know it's this person? But that's a whole nother question here. But I was next door to this person. Have I been exposed? I've been in classes with this person. Have I been exposed? And just for context, in our classroom, you're mandated to be masked, except for the professor who, if they're speaking, is not. Same way that if you're in your room, you're not masked, but when you're outdoors, out of your room, you're a mask, etc. So can you all please explain to us it talks about prolonged exposure. What is the definition of prolonged exposure? Because I think we need to put that one to rest very quickly here.
So we're talking about testing people who are the closest contacts first. And so prolonged exposure generally means, and this is sometimes a little frustrating, but about 4 to 8 hours per week in a small closed-in area, so not outdoors, in things that also contribute to the spread, poorly ventilated, certainly unmasked. Those are what we're talking about, prolonged close contact. And those are people that we want to test first as part of the contact investigation.
So I want to repeat what Jason just said, because I think it's incredibly important for everyone to hear this. Because we keep hearing from people, I may have lived next door to this person. I may have come across this person. The definition of prolonged exposure is 4 to 8 hours a week with this individual, and in an area that is potentially not well ventilated. And so being in a class with a person where it's an hour and a half or 15 minutes at a time when you're masked. And in the case of American University, I do want to remind everyone, we did our HVAC ventilation project for COVID for both our residence hall and all of our classes and all of our facilities. So I think that context matters, because that's one of the first questions we're getting, Dr. Rosario and Jason, is, oh, I was next door in a room separate from this individual, or I was a faculty member, I was a classmate sitting with this individual in the class. And I want to make sure people understand the notion of the prolonged exposure piece, the prolonged contact piece, and what are the conditions that have to be in place. And if you can please talk a little bit about that, you're starting with the people who are most close contacts, who would have met those guidelines first, and then you're working your way through based on your contact investigation. If you can please speak a little bit more about that part of the exposure part.
Yeah, so we are doing that, and what that may mean is that we touch base with the very closest contacts first. It's not to say that we won't touch base or get in contact with the people who were in class with the case.
That's right.
We may do that.
Yes.
We may do that. And then other people, as we get information about contacts, we may have to contact them. So there will be people that are already notified, and then there will be people that will be notifying soon. And then there may even be people after that will get a notification even later, depending on how many people in the initial groups, if any, test positive.
Okay, so then let me ask this question. My daughter lived next door to the student with TB. She currently has a test scheduled for tomorrow. Should she go ahead and do the test, or should she wait for the DC Department of Health?
Yes, okay, so it's a good question. It sounds to me, based on the scenario you're describing, that she could go ahead and, you're talking about doing an exam, right? Like
it says, yeah, it talks about taking the test. I'm assuming it's taking the test to determine whether or not the person has TB.
Oh, I see. I think that depends on if the person is having symptoms that they're worried about, that may be a different discussion. But if the person is not having symptoms and they weren't contacted by us as a close contact, then I would say they don't have to limit activities.
The thing is that, the health department is going to contact the people that are identified to be close contacts. So that determination will be made, and those people will be informed to be tested in a way. If there are people that are worried, that then, it depends upon there is a judgment call in a way. If they're worried and then they want to make sure that the people can have can be tested. These are the people that are worried, but the ones that are identified by the health department are the ones that will be identified and then will be called for testing. I think that the one that have been identified to be those are the people that are at risk at that moment.
Right.
Okay.
We will be contacting the people that are identified as the closest contacts directly. So they won't have to guess about whether they're in that group. Now, we also recognize that people may arrange for testing on their own, but in terms of people that we are concerned were close contacts, they will get communication directly from us by a combination of phone, email, and at times letters to home address. We may do all three in some cases.
Okay, and it would be an official notification from the DC Department of Health, as you said, in the form of a phone call, in the form of an email, in the form of letter mailed to a home address. And all of those are information that the university would provide to the Department of Health for your contact investigation. So the same question, what should professors who have had contact with a student with TB do at this time? The student disclosed to me that they were diagnosed, but I haven't been contacted by the DC Department of Health.
Yeah, so that we do get that question. And as the contact investigation progresses, we do get notification from different sources about people that feel like maybe they were at risk. And if they contact us, we'll take a look at that based on what the index case has shared with us, based on what the university has shared with us, and do our best to determine if they meet our criteria for a close contact. But by and large, we're taking the information that we get from the index case themselves and the information that's been provided by the university um, to take our list of closest contacts first.
Okay. Can you all give us a sense of what's the timetable for the contact tracing?
So the contact tracing has already started. We will be, as soon as possible, in touch with people, but by the methods I said, by phone, by email, and ultimately by snail mail. I can't give you an exact time frame. We're working as quickly as we can. We're very grateful for American University's cooperation. You all have been phenomenal in arranging access to the campus for us to go and do a walkthrough of the spaces and tour the area. And then we'll be identifying an area in all likelihood where we will come and be able to do on-site testing there. Contacts will have the option of coming to our clinic if they prefer to come here for testing, if they're part of the contact investigation. And so while I can't give an exact day, we are moving quickly, and we have already been in contact with some of the closest contacts.
Thank you. So we're getting a couple of questions. My student is not feeling well. They have body aches, fatigue, they may be coughing, etc., and so forth. What should I do? And I think we want to start with the fact that prior to you knowing about a TB case, we've had students who have not been feeling well. So perhaps Dr. Reitman, can you just refresh everybody's memory about what people should be doing if somebody is not feeling well?
Yes.
Because there may be lots of reasons why they're not feeling well.
Yes, and I think it really is important to really remind everybody that we've been seeing lots of students coughing for years, and they do not all have TB. And we're seeing lots of students coughing with all kinds of different things. And usually at this time of year it's the common cold, but we've had some students. We've had a few students who've had COVID. And so I think that first of all, if students are waking up with these kind of symptoms, the first thing they should do is they need to get COVID tested. Okay, and that they can do at Constitution Hall and just walk in and do that. And the hours for that are posted on our website. Students who are, if students have been having more of the persistent and more severe symptoms, especially like Jason Beverly was just saying before, in terms of having chronic cough. So the cough that's been lasting for more than just a couple of days, but been lasting more than a week, having fevers, night sweats, and weight loss. And persistent fatigue, they need to be evaluated. There's lots of things that could be, and tuberculosis is in the differential diagnosis for that, but it is not the most common thing that's going to be. And this student could very likely could have mono, or could have the flu. So I would say in those situations, we would recommend students make an appointment to come in for a sick visit into the Student Health Center, and the appointments are available. We've got same day appointments that students can call 8 a.m. to get an appointment for that day, or they can go online and make their appointments online. One thing I would like to just mention, dovetailing on what they were saying about testing, is that we're going to be testing students. We've got tests to test, and the ability to test students who have symptoms that we're worried about tuberculosis. Okay, to be testing them. We do not have the test kits and availability to test every single student who thinks that they're worried, they want to make sure they don't have TB before they go home for Thanksgiving or anything like that. We just don't have. There's a lot of test kits involved, and so we are saving our test kits for students who are sick that we need to be able to identify, could the student actually have tuberculosis. But that's what we're going to be doing right now in the Student Health Center. So I just want to kind of set that up as as an expectation.
And I think what's important for people to remember is that the DC Department of Health is leading the investigation for contact tracing, and will be making the determination of testing and who needs to be tested. And while we're at the conversation about testing and who needs to be tested, can you remind this group, generally once a person gets the test, how long does it take to get the results of the test?
The test company, LabCorp is saying that it's a 5-day turnaround time. We've been getting them back at around 3 to 4 days, but there is a few days turnaround time. It is not an overnight. It's not a rapid test the way that we have for some of the strep tests and that kind of thing that we do in the health center. So we will, if a student is symptomatic, and is having cough and fevers and that type of thing, and we are doing a tuberculosis test on them, we are expecting that they are going to do a quasi self, I don't want to say isolation, but they're going to be limiting their activities and not be going to classes and going to social events, that kind of thing, while we're waiting for their tests to come back. So
yeah, thank you for that, Dr. Wagner, because we have about a 3-day turnaround for our blood test for TB as well. And just wanted to just sort of review the types of tests that we're talking about. Dr. Rosario was referring, when he says a TST, he's talking about the skin test, the PPD, the traditional test that you come back 2 to 3 days after you have it placed. When we're doing contact investigations, we prefer to do the blood test, and that's the IGRA that Dr. Rosario was talking about. When we say IGRA, that's a blood test for TB. Why do we prefer that? One, you don't have to come back for a reading 2 to 3 days later after you get it done. 2, it's very sensitive. And 3, we don't get false positives because people got the BCG in their home country. So for students that were born in an area where TB is very common, which we use the word endemic to describe that, where people who might have received the BCG vaccine, if they get the skin test, they might have a false positive. But we don't get that with the blood test. So that's why we prefer the blood test. And then you say, well, why don't we just test everybody for TB to be on the safe side? And the truth is that not everybody in all likelihood would need to be tested. We will, in a targeted way, test anybody that needs to based on their exposure risk.
So then,
one thing I forgot, very important. As part of the contact investigation, it's important for us to do an initial test for TB, and then 8 to 10 weeks later, we will, in most cases, have to do another test to make sure that there's no TB there. And so that's important for people to know. They'll be getting contacted now, and then we'll be telling them 8 to 10 weeks later, we're going to need to do a second test. Well, what's coming in about 8 weeks? Christmas. So we may run into the 8 to 10 weeks. We may test some people when they come back from the winter break. So just to put that out there, for most of our close contacts, when you get notified, it is going to be a two-test process.
Thank you for that, because that was one of the questions was, is there a system in place for the ongoing monitoring of those that you would deem have been perhaps exposed? And what I'm hearing from you, Jason, is that there's a 2-step to it. You may be tested the first time, but within an 8 to 10 week period, you will also be back in contact with them for a second testing.
That is correct.
Yep.
And then after that, if the second test is negative, then we don't, in terms of ongoing monitoring, that should not be needed for people that test negative on both the tests.
Absolutely. Especially the second test is very important, because people who are in the incubation period, we can cut the time that we catch them is when we do our second test. So I just want to emphasize that when they have the test, to make sure that they are also go through the second test, which is very important to make a determination who is infected and who is not.
Okay, so just again, because placing myself in the shoes of some of our colleagues, so there are a couple of things I want to make sure I am understanding. One is that, to the question of, I think I may have had contact with the patient. I've not yet been contacted by DC Department of Health. Why might that be the case? That's because based on the initial investigation, you're not deemed among the closest of contacts from an exposure perspective. That's really the answer there. But as you investigate and you're getting more information, then it's going to extend to the next level of potential stakeholders. Right now, you have the roster of classes, you have a list of the names and everything. So you already have at least that preliminary information is what I'm hearing. The other thing that I'm also hearing is once you have been contacted, which would be by phone and or by mail to individuals, etc., then probably testing would happen either at American University or it would happen at the clinic, and you're moving as quickly as you can around those closest of potential folks who may have been exposed. Once you're deemed exposed, then there's a 2-step process. First testing now, and then within 8 to 10 weeks. And as Dr. Rosario said, that's incredibly important for people to be aware of that. And so there is that monitoring that will be taking place. Can you all help us understand a little bit? We're now in a time of COVID, right? So some of the symptoms you've described are some of the same symptoms as COVID.
Yeah.
So explain to us a little bit here how we can kind kind of make sense of these two things here?
Yeah, so some of the symptoms of COVID are the same. Cough, fever, um, both are common with TB and with COVID. However, some of the other things that we see with TB aren't as common with COVID. So the weight loss, the night sweats we don't see as often with the COVID virus. Blood in the sputum isn't as common with the COVID virus. But there is overlap here. And so what Dr. Reitman said, first, I would say, I don't know what AU's policy is, but the general suggestion is if you're feeling sick, stay home. If
Yes.
you have cough, fever, shortness of breath, whilst it's more likely to be COVID than it is to be TB, in either case, you should not be coming out if you're sick. But is it TB versus COVID versus an upper respiratory infection, upper respiratory virus that is really common right now with weather change and this time of year? Much more likely to be that, much more likely potentially to be COVID than it is to be TB, even in the face of an active case. And that's really hard to remember because people are appropriately concerned that there's been an active case and there have been people around the active case, but there's still more likely explanations. And if you're feeling sick, don't go out, call your doctor, take direction.
And what we're suggesting, Jason, is if you're sick, you're not feeling well, go and get your COVID test.
Yeah.
Let's start with the process of elimination, and the COVID test is offered right here at American University. That's the first step.
Right.
That we're really strongly advising folks that they would want to take and they wouldn't want to take on. And then if it's consistent, after you've eliminated that possibility and it's consistent, not feeling well, it is to consult with our student health center, understanding that the team at the DC Department of Health is doing the contact investigation specifically related to TB. I think that's the advice that we would provide. I don't know, Leanne, if you have something else you want to add to that, but that's really where we are in relations to how we want to have people think about this.
I think that is a good way of putting it in a way, because COVID and the flu are an acute diseases, while TB is some sort of a subacute, a slowly progressing disease in a way. So I think first is to rule out the acute, infection. Is it flu? Is it COVID? And then if it doesn't get better, or if that is excluded, and to go to the next step, trying to rule out TB.
Yeah, and I just want to reinforce being proactive in your own care. So to really, if you feel sick one day, get the test that day or the next day, very quick. Don't wait 3 days. We see sometimes students waiting, I think because upper respiratory viruses right now are so common, to kind of put it off. And then they're still feeling sick days later. So please go and just get that COVID test immediately, and then call the student health center if you're still feeling under the weather, not waiting weeks and weeks.
Right. Good point. And I think it's a good point in our conversation to say that the majority of time when we're doing contact investigations and we find people who test positive for TB, the majority of those people have latent TB because of the way that it typically progresses in young, otherwise healthy people. It's more typical for them to have the latent infection for a longer period of time before, if they will ever develop active disease before that happens. So it makes it even more likely that if there's symptoms of some sort of lung problem, it's much more likely to be COVID or some other type of virus than it is to be TB, active TB disease. Based on the normal progression in most people.
And one of the questions that were asked was, what is American University doing to mitigate this? I think what we're doing to mitigate this are, interesting enough, some of the measures we have in place for COVID, right? We're asking folks we've been asking to get masks. We've been asking to get tested. We've been asking you that if you're not feeling well, please, really limit your activities and certainly have your mask on at all times. and make sure you're getting your COVID test. Those are some of the things that we've been asking for that are going to be incredibly important. And I think, David, Jason, and Dr. Rosario, one of the questions that also comes up is, let's assume that I may be the TB patient, but I wasn't masked all the time. But you, on the other hand, in interacting with me, you're masked. I would assume that is also protecting you because you're masked.
Absolutely. Yeah.
I mean, I think that's the other thing that people forget. Masking is really important, not just for the person themselves, but for also others. So as long as you were masked during the period of time of interactions or contact, that becomes important to keep in mind as well, because that was one of the questions that was asked, was if I'm masked, but the other person may not be, I'm protecting myself as well because I'm masked.
Absolutely. In fact, this year, what we have seen, I don't know if that's the same experience. We have seen very less flu and cold. I think it's the effect of the mask.
Yes.
So this mask is really, really helping in a way. I think stressing about wearing masks at all time, I think is very important information to pass, including for the TB.
Okay.
Yeah, it does. It certainly provides protection. We can't say it is 100%
100%.
these type of masks especially, but the combination of the person with active disease wearing masks most of the time and other people wearing masks most of the time really is really helpful, although it doesn't completely eliminate transmission risk.
And I have a question here. What is the range of incubation period from exposure to positive tests for whether it's latent or active? And then in particular, if I'm someone with a chronic lung condition, right? What does that mean for me?
Okay, the incubation period from exposure to positive test is usually 4 to 8 to 10 weeks, starting from 4 weeks to 8 to 10 weeks. That is the incubation period. And that's why we do the two testing. We test initially, and then we test about 8 to 10 weeks out from the last day of exposure. Okay, that's how long it takes for the blood test or the skin test to be positive. The impact of a person who had a chronic lung disease when they have TB, the problem is that it can worsen the lung problem, because a person who has already some fibrosis in the lungs, and then if they get TB now, it can worsen that fibrosis, and then it can compromise their respiratory system much more. So that we have seen.
And this is a good point to say that anyone, regardless of underlying illness or not, if they're in our group of close contacts, they'll get a test. What happens after someone gets a positive test on the TB blood test? Well, then what's going to happen is we'll offer for them to have an evaluation by our clinic. They can also get it done by their doctor as well. We go through those risk factors that could make TB a more complicated diagnosis for them. We're going to look to see, are they having any symptoms of active disease? And we have ways to figure that out. And then we can offer treatment whether they have latent disease, which is the most common thing. And again, latent TB infection means you have TB in your body, but it is not making you sick and you cannot transmit it to others. Really, really important. So we have treatment for that, or if for some reason there's indication of active disease, we can offer treatment. But the same test will be done regardless of that underlying health condition. The way we handle it, if there's a positive result, could change based on that underlying condition.
And so I think the important message that I'm getting from this is, if you're considered to be part of that group that had prolonged contact, and you're deemed to be potentially exposed, you will be tested and you will be monitored over a period of time.
Correct, at least until that second test at age 10 weeks.
Okay, can you repeat once more, what is considered prolonged contact?
It's me, yeah. Prolonged contact is, just to give an example, one is that if a person had more than 15 hours of exposure within a week.
15 hours.
Yeah, 15 hours. Or to give you an example is that, for example, if somebody is exposed in an airplane, which is considered a close contact because people are in one plane, is 8 hours is considered as, you know, the duration of time.
I think we're having some technical problems. It might be just me, but I think we're having some technical problem with our colleagues at DC Department of Health. But what I was catching from this, Leanne and Dr. Reitman, is 8 hours or more in the case of a plane, because everyone is within that same confined environment over a period of time, was what I caught with that. And so that was one thing that came up. And then I think people are asking questions about, does it matter whether you're masked or unmasked during that prolonged period of time? Dr. Reitman? We can't hear you.
Okay, can you hear me there?
Yes.
Yes, masking is going to help. Okay, just like it does for COVID, masking will dramatically, especially if the person who has tuberculosis is masked and has the face covered. That is going to catch a much of the bacteria. Remember, this bacteria is much bigger than the viruses that we worry about with COVID and that type of thing. So it will be caught by the mask much more readily. It is, is there a possibility that, that somebody, was taking their mask down and eating and drinking and then putting, there was always that possibility there, but for sure, masking, sitting in the classroom being masked reduces the risk dramatically compared to what it would be if there was no masking available. Jason, are you guys, can you?
Jason and Dr. Rosario, please. Yes.
Back. Okay.
Yeah. So yeah, I was just talking with Dr. Rosario. We can see that a lot of people that are concerned probably don't meet the definition of the closest contact. We may end up testing other people as the health department. And after we take a look at the campus, the classrooms, and the areas where the students live, we'll have a better idea of who we need to test. And sometimes we're cautious and we test other people that don't meet that exact strict criteria, but that is the criteria. And so you can see that it's not just people who come in passing contact that meet that definition.
And so one of the questions, as you very well know, Jason and Dr. Rosario and others, we're getting into Thanksgiving. And one of the things I have to say I love about our community is really this sense of shared community responsibility. So people will be going home to families and others and concerned that they may potentially unintentionally expose others while they're there. So the question that's come up is, are you concerned about students going home for the holiday if the incubation period is 8 to 10 weeks? What is the risk of potentially infecting others during that time?
Yeah, so I would say, and Dr. Rosario, please chime in, or Dr. Reitman, I would say if people are having symptoms of cough, that they wear a mask and limit their activities. Again, why? Well, it's more likely to be COVID or some other upper respiratory virus than it is TB. But if by chance it was TB, that's unlikely given the normal progression in young, otherwise healthy people, but the mask would help mitigate transmission in that case and the limiting of activity.
Yeah, I mean, I agree with that. And, if they have an acute symptom, the possibility of the COVID and the viral illnesses that we're talking about is there in a way. But even then, they have to protect others, especially this time that we are in. So taking and getting that precaution is very important.
And getting a COVID test and
definitely,
calling a healthcare provider.
And we are recommending to everyone before you go home, get a COVID test. And the same way when you come back from home for your American University home, get a COVID test. That is the strong recommendation that we're providing to our community. Again, the question is coming up of this weekend was Halloween. There were many parties this weekend off campus and so forth. Was exposure done there? I think we have to keep reminding people about the fact that it's prolonged contact. So my question to all of you would be, were you at a party for 8 to 12 hours unmasked during that entire period of time? I mean, these are important questions that we need to keep reminding our community about.
Right, right.
This is not you pass somebody by.
Right. Yep.
Yeah, I think that that's a very important information to pass, because TB transmission, you need a close and prolonged contact. Is casual contact is less likely to cause transmission. I think that that information is very, very important.
And one thing that we didn't talk about is that we don't believe TB is transmitted from surfaces. We don't think it's transmitted from sharing utensils, sharing vaping equipment, sharing cigarettes. So I don't know if that question has come up, but
but I think that's relevant to the discussion, right? Because what we're getting from this is people may have been in spaces celebrating and all of that, and I think the operative word is prolonged. And it's also the nature of the contact that was taking place during that period of time. Unlike, for example, COVID, where you shouldn't be sharing utensils, right? We talk about that. So the threshold for COVID is actually much lower when you think about exposure, and the amount of time it takes for contact for that to be potential exposure is very different from TB, where it's much more prolonged contact. So I think those are some of the differences that I see there. The other question is, how long does the Department of Health monitor the affected patient in regard to compliance with the medication regimen? How long is the medication for, and what kind of monitoring happens as a result of that?
you have to be careful. Yeah, without talking about specifics to this case, typically the health department follows the person until they have treatment completion. And treatment completion for people with active TB disease can be anywhere from 6 to 12, in some cases, 6 to 12 months, in some cases even longer. And so the health department in the local jurisdiction to the active case does follow that case typically very closely until treatment completion, and then even after. Anything you want to say there?
About the infectivity, we clear them when they are non-infectious.
Yeah, so after a person with active TB disease has been on medication for a while, and we consider them no longer infectious after they've been taking the medication for a while, and we have certain lab values that we follow while they're being treated, we can often clear them for going back and having normal activity, not being contagious. So it doesn't mean that they can't have any normal activity for 6 to 12 months, or some cases even longer. It means during the period where we determine them to be infectious or contagious.
Okay.
Yeah, that's what we do generally. When we have active patients here, we monitor the patients whether they are infectious or not. So they will be cleared, to go to work or go to school once we make sure that they are no more infectious. So there are lab values that we see, the sputum results that we check before we clear a patient.
So one of the questions that is attached to this is, how about individuals with no symptoms? I understood from you that based on the definition of prolonged contact, whether a person has symptom or not does not matter. You're going to be doing contact tracing, right? You're going to be doing the contact investigation, and you will ask that people be tested whether they have symptoms or not based on the definition of prolonged exposure. How about those who have no symptoms?
Yeah, that is a good question. Let me clarify that in a way. The purpose of contact investigation is two. One is to identify patients that have been exposed and who have developed infection. TB infection is not transmissible. It doesn't pass from person to person. This is what we call latent TB infection. And then that is what we see commonly. So those patients who have latent TB infection, we treat them, we identify them first. Why? Because we want to treat them before they develop active TB disease that passes to other people. So that is the purpose of the contact investigation, to identify the people that have been exposed and infected so that we can intervene and treat them before they develop active TB disease, so they don't develop active TB disease. That's
And
one. The other one is that people who few, very rarely we find secondary active TB disease. This is patients, especially in patients who are immunocompromised. That can happen, but it's very, very rare. And then if they are symptomatic, we will also investigate to make sure that they don't have active TB disease. If they have, then we treat them and we make sure that they don't pass it to other people.
okay. And just for clarification, by latent TB, you mean folks with no symptom? Is that what we're talking about?
Yes,
That's the definition of latent TB, is people with no symptoms.
right. Latent TB means patients who've been exposed. They have the bacteria in their body, but it hasn't started damaging their body in a way, so they don't have any symptoms of TB disease. And then when we do chest X-ray, there is nothing showing there, and they don't have any symptoms of TB disease. And these patients, by definition, they don't pass the infection to other people.
Mm-hmm. Very helpful. Then the other question for clarification is patients with latent TB receiving treatment, they don't need to quarantine. Is that correct?
Absolutely. Patients who have been treated for latent TB, they don't need to quarantine because they are not infectious. They don't pass it.
Okay, helpful. And is it the case from your work with TB that most of the cases tend to be latent with very few active, or what does that look like generally, out of curiosity?
Well, I mean, the majority of patients who've been exposed, they develop latent TB infection. So out of the people that develop latent TB, it's about 5 to 10% that will progress into active TB disease in a lifetime. So the majority have latent TB. If let's say if people are exposed, the majority, about 90 to 95%, will be the people with latent TB. They're not active TB. Out of this are the ones that will develop active TB, is about 5 to 10% chance in a lifetime.
Mm-hmm.
So the majority of people after exposure, the first thing that we see is latent TB infection.
Okay, helpful. So I just want to make sure to summarize a bit, and please add or correct from my summary. First and foremost, as the DC Department of Health, you have the information you need in order to and you've already started your investigation, your contact investigation. So that's the first and most important information. And you will be contacting people either by phone or by email and or by letter that could be addressed to them coming directly from the DC Department of Health. If people are deemed to be of the prolonged contact and therefore potentially exposed, they will be tested. Testing will happen either at American University, you will coordinate that with us, or it'll be at your clinic. You will be monitoring those individuals because there's a two-step. First step now, and then 8 to 10 weeks would be the other step that would be part of this, and it's going to be important for folks to take that into account. If anyone has concern because they haven't been feeling well, know that in this time period between COVID and other respiratory illnesses that are going on, they should be tested for COVID, and or if they have symptoms that are going on, they should consult with the Student Health Center, knowing that as TB is concerned, the DC Department of Health is doing the contact investigation. So if you haven't been contacted, it's probably because one, you're not considered among the immediate ones potentially exposed, and they're doing the work that is needed to move that forward, is what we want to make sure we understand. And latent TB is not transmissible. But part of the reason you're doing the investigation is you want to catch it early enough so that it doesn't necessarily turn into active TB, even though we know that there's a small percentage of cases that move from latent to active. You want to be, out of an abundance of caution, you want to make sure that that happens. Key is the COVID measures we have in place works and helps us with not only COVID, but other airborne respiratory issues. And so keep masking, and let's make sure we do that, are the things that I'm getting from this conversation. Certainly anyone who has heightened anxiety is welcome to get tested, but more likely than not, you may be dealing with other issues of respiratory issues than most likely TB. Did I capture that?
That's a great summary. Thank you so much, Ms. Ganta, for that. And I would just say the very first thing, we have a lot of the information that we need for the contact tracing, but not all of it. We're gathering some as we go. So there may be some people who feel that they are a contact, and maybe we will eventually determine that that's the case, but there may be some that get notified at one stage and some people will get notified later, just as we gather more information.
And I think the most important part there is if you hear from DC Department of Health, please respond immediately.
Thank you. Yes.
Right.
Please.
So I think probably that's a message you want to take back. And then lastly, an audience member said, please wish the student infected a speedy recovery. That's the kind of community we have here. So I just wanted to make sure to pass that along. And also, more importantly, we really do appreciate the partnership with DC Department of Health and your quick response to this. But also for our community, know that Dr. Reitman is here, Leanne Wright, and they're in constant contact with DC Department of Health, and we're coordinating our efforts through this process.
Yes, we have, and likewise, we want to say thank you to all of you at American University. Dr. Reitman, first and foremost, for notifying us right away, for thinking about TB as a possibility. We're so grateful. And then the rest of the folks on this call should know that the American University faculty that we're working with appear to passionately care about the campus community, because they are working very, very closely with us and doing literally everything we're asking. So thank you very much for the partnership.
Thank you. And to all members who joined us this afternoon, thank you. We appreciate that. And I think we just want to make sure we continue to exercise our due diligence, and let's make sure that we continue to take all of the measures that we're currently taking in relation to our community. But thanks for joining us. And know that if you have additional questions along the way, please don't hesitate to reach out to those of us who are here. And to our colleagues at DC Department of Health, thank you for your partnership. We very much appreciate your work.
We're a team.
We are, absolutely. Thank you, everyone. Have a wonderful evening all.
Thank you, Mike.
Take care. Bye-bye.